Hello, my name is Lorna. I am a tutor at Chrysalis and I'm also a psychotherapist. And today I'm going to be taking you through an aspect of Component 5, which is abuse and addiction. And in particular, we're going to be focusing on Module 7, which is addiction and dependency. We'll be looking at physical and psychological dependency, substance abuse and process addictions. And we'll be looking at some of the tools and techniques and methods that can be used to assist clients who may like to be changing the issues that they're experiencing. So we'll be looking at the cycle of change and motivational interviewing. So defining addiction. So first of all, the word addiction is important, I think, to discuss and to really reflect on. So, many therapists, many agencies, indeed many clients don't particularly like the term addiction. It implies something that can be impossible to change, something that is fixed, something that is, that is just very, very difficult to work with. And addiction also sort of implies that actually, it's related to a substance, and that is not necessarily the case. So, when we are looking at addictions, we can also be looking at compulsions, dependencies, okay? So, looking at this grid here, if we start with substance dependency, that is where actually the body and the mind goes through neurobiological changes because of the substance that is being used. So certain substances create these neurobiological changes and certain substances don't. Those that do include alcohol, heroin, some painkillers, some antidepressants. And here the body has adapted to regular exposure to the substance. So what actually happens in this case, that there are chemical changes within the nervous system, within the body, and that is what is happening when the body becomes actually dependent on that substance. So those particular substances I've just listed there are ones that can lead to a dependency, can lead to an addiction, and if that particular substance is stopped completely, very quickly, then that can lead to quite a lot of problems, and in some cases really severe problems. So that's something to bear in mind, that actually sometimes medical intervention is necessary if people want to stop taking these types of substances. Then there is dependency on non-addictive substances. And you might be interested to know that there is a very wide range of recreational drugs that we might think are addictive, but actually they are not. So that doesn't mean that people don't feel compelled to take them, and that they build, if you like, a psychological dependency, but the substance itself is not addictive. So substances here include cannabis, cocaine, amphetamines. Okay. So then let's look at process addictions. So process addictions is where actually there's no substance involved. But interestingly, there will still be neurobiological changes and an addictive pattern that occurs. So, for example, gambling, sex addiction, can create significant negative consequences where people find it really, really difficult to stop. To find that they're actually feeling a certain way when they want to undertake that behaviour, when they do undertake the behaviour, when they're not able to undertake the behaviour. So still significant neurobiological changes that are happening. And then non-addictive behaviours, so paraphilia, social gambling, social drinking, occasional recreational drug use. So here, the behaviour is not a compulsion. It doesn't interfere with day-to-day life. And what this shows here is that actually somebody who undertakes any of these behaviours or some of these substances doesn't necessarily have to, it doesn't have to lead to an addiction. So people, it's not a given. It's not a given, okay? And that's important to recognise, because then we are back to the knowledge that we already know well, is that in many cases, this is very much related to the individual person, their circumstances, their environment. It's not just the substance or the behaviour itself. So physical dependency may occur with the regular use of any substance, recreational or prescribed, and that's important to recognise as well. So it's not just those illicit substances such as heroin that people can become addicted to. So people can become addicted or dependent on prescribed painkillers. Okay, and similar types of medications, and obviously the prescriber is very careful about ensuring that doesn't happen as much as possible, but it does. And some clients might not realise actually that when we are asking them about substances they're taking and so on, that there is a chance that they do feel that they have a dependency on that substance. Now that's complicated because very often, for example, a strong painkiller, like tramadol, for example, is going to be prescribed for a physical condition, for a medical condition. So the person, knows that there is a risk of dependency, but still needs to take the medication. So that's something that that we have to bear in mind. So dependency occurs because the body naturally adapts to regular exposure to a substance. And when that substance is taken away, symptoms can emerge while the body readjusts to the loss of that substance. One such example of this is alcohol, for example. So alcohol provides certain amino acids to the body, and when the body is receiving those amino acids externally, it no longer needs to produce them itself. So the production slows down and in some cases stops, and then when the alcohol is taken away, if it's taken away too quickly and too soon, then the body is depleted of those amino acids either internally or externally, and that can leave people at quite serious risk. Physical dependence can lead to craving the drug to relieve those withdrawal symptoms. And yes, they can be severe, they can be distressing, but at the very least they are uncomfortable for people as well. Psychological addictions create a dependency in the mind of the person. So it's not a need to prevent the unpleasant side effects of withdrawal from a substance, but there is a process that happens with psychological addictions. So there is, there is a cycle, if you like, of wanting the behaviour and then getting something from the behaviour and feeling good about the behaviour, and then the withdrawal. So dependencies can generate from a need to reduce feelings such as anxiety or isolation, and that's something that we'll look at in a short while. So most of us know pretty well the effects of alcohol. Okay, so if people are alcohol dependent, then they have a strong compulsion to drink. They may drink at inappropriate times. They may drink shortly after waking, and they may have a reduced capacity to control their drinking, and they're finding that their life is organised around drinking. So we find a similar type of pattern with other substance addictions, okay, that life begins to become organised around the drinking. So if drinking is not involved or the substance is not involved, then people are not doing those activities. So 3 million deaths each year in the UK are attributed to alcohol. Now, let's be clear that that's not necessarily from the consumption of alcohol, but it is the effects of the consumption of alcohol as well. So this will include accidents, reckless behaviour, for example. So 13.5% of all deaths are in the age range of 20 to 39. That's very high, isn't it? So, age range of 20 to 39 is the age range where we consider that, most people would be continuing to live a longer life. And alcohol is attributed to 5.3% of all deaths in the UK. So, effects. Again, I think many of us know the effects of alcohol: slurred speech, loss of coordination, unsteady walking and standing, impaired attention, impaired judgment, loss of inhibitions, sleepiness, and can certainly react negatively with other drugs. The effects of withdrawal. So here we're not talking about the hangover, okay, but we are talking about withdrawal from somebody who is dependent on alcohol when they can no longer have the substance, an anxiety, a restlessness, insomnia, elevated blood pressure, disorientation, and then short term, so hopefully hallucinations, psychotic behaviours, occasionally grand mal seizures, and sometimes sudden death. So this is serious, and if a client talks to you about wanting to stop their level of drinking, then it's really, really important that you take a very careful and thorough case history, and the client is very clear and honest about the level of their drinking and the frequency of their drinking, because people with dependencies or addictions tend to downplay the issues of the substance or the behaviour that they're engaged with. So, and then you have to be very clear about your level of competency here, and not just your ability to support somebody who wants to change their behaviour for a positive reason, but also your ability to support that person medically, physically, and best done as part of a team. So many people who want to withdraw from quite severe alcohol consumption do so under medical supervision, sometimes as an inpatient, sometimes under the care of their GP. Okay, and if you feel that the person who wants to change their behaviour is not just an occasional drinker, then you have a responsibility to ensure that they are directed towards the right support, and that would start with an appointment with their GP and a consultation there. So we've talked a little bit about alcohol. In your course notes, you'll find that there's much more material about this. But classes of psychoactive substances fall into different categories, and let's look briefly at these here. So there are the opiates, okay, and these provide pain relief. And they do so very effectively because they actually mimic the pain-killing capacity of our body. Okay, so the endorphin production within our body. Endorphins have a very similar compound to opiates. So opium, morphine, codeine, tramadol, heroin, methadone, all within this class of opiates. Okay, and there will be more. Depressants. So depressants act as a sedative, and they slow down brain function. They promote sleep, they reduce anxiety, and in this class are alcohol, sedatives, tranquilizers, benzodiazepines. Stimulants increase attention and alertness. They increase confidence. So caffeine, nicotine, yes, they are drugs. So Ritalin, Dexedrine, amphetamines, methamphetamine or crystal meth, cocaine, crack cocaine, these are stimulants. They increase alertness. Hallucinogens, LSD, magic mushrooms, peyote, mescaline, salvia, ketamine. And marijuana, cannabis, skunk, both a stimulant and a depressant, and in fact in some cases a hallucinogen as well. So different classes, and if you are working in the area of addictions or dependencies, then it's going to be important that you do understand the type of substance or substances that the clients are taking, and that you understand their effects, but you also have an understanding of how they are affecting your individual client, because clients or people generally have their own reasons for starting to use a substance and continuing to use a substance, and they have their reasons for making the choices what substance seems to suit them. So yes, our general understanding is that if we are feeling a distress in some way that can be assisted with medication, then people can be, for example, prescribed antidepressants or anti-anxiety medication. But increasingly, we are recognizing that a lot of people use recreational drugs as a way of self-medicating. They self-diagnose and they self-medicate. They find something that is working for them, whether they feel they need extra confidence or whether they need to reduce their level of stress or anxiety, and then they are choosing something and actually prescribing that for themselves. So, moving on from substances, let's take a little look at a process addiction here. Okay, so gambling is now actually, unfortunately, a significant issue in the UK. So gambling has, changed significantly over the last decade or so, where the ease of gambling, online gambling, being able to use credit or debit cards, having credit, being able to access gambling all of the time, it being relatively easy and it feels comfortable, has certainly increased the level of gambling. And gambling being a process addiction means that it is actually very easy to find that the level of gambling creeps up and up and up and can become a really significant problem for people. So, unfortunately as well, there's not an awful lot of psychological support for gambling in the UK, and there certainly needs to be more, because people can find themselves in extremely difficult circumstances if they find that they cannot control this behaviour. So categories of gambling start with what we call social gambling. Perhaps that's something that that many people partake in. So they have a flutter on a major horse race, or perhaps a big football match. Social gambling, gambling occasionally with friends, associates, with limitations. Once in a while, it doesn't feel like anything. It's a bit of fun. Another category is professional gambling. So there are people who actually think very carefully and rationally, with discipline and with planning and with lots of calculations. That's assessing the risk, assessing the chances of loss against a win, and actually do this as a profession and limit the risk. Problem gambling, that's when it's starting to become a preoccupation. That's when it's moving from a habit into something else, and that it's beginning to overtake other interests, other things that need to happen. It's beginning to overtake where money needs to be spent, for example. So a preoccupation, a narrowing of interests. And then what we're terming pathological gambling starts to come alongside that pattern that we've looked at previously, distortions of thinking, a denial that there is an issue, a superstition that something really great is going to happen today because, an inflated sense of confidence, an inflated sense of power or control, a knowing that something good is going to happen. So the phases that lead to pathological or problem gambling. This can be a similar pattern, by the way, with other process addictions. Okay, so we're using gambling here as an example of process addiction where there is no substance involved. So the process, first of all, it's the winning phase. So, if we think back to what we know about, basic behaviourist principles, then one of those basic principles is that we tend to do something more if we receive some kind of perceived reward for it, and we tend not to do it so much if we don't get a reward for it. So, if somebody gambles a little bit and always loses, then perhaps gambling just isn't for them. And they don't keep thinking, I shall just gamble some more. They just leave it alone. It's not exciting. So, many people who are gambling frequently talk about, that first win, how that felt, that sense of elation, that sense of power, that sense of control, that real excitement. And, that reward it sticks with them. It doesn't necessarily have to be a huge financial reward, but just, the excitement and the elation of the win. Something has shifted for the person. Perhaps they were feeling that, that their self-esteem was low, their sense of worth is low, that, that life is mundane, there's no hopefulness about it, and then this thing happens for them. And something switches, something changes. So what happens when we get a reward for something? The behaviourists say we tend to do it again. So now we want that feeling again. We want that sense of elation again, and we know how to get it. We got it before through gambling, and now we can get it again through gambling. But then the inevitable happens because, as we know rationally, as everybody knows rationally, gambling long term can never win. So the odds are simply stacked against it. That's why gambling organisations make a lot of money and people who gamble generally don't. So, the equation rationally is just stacked against continuing to win. So the inevitable losing begins. But then the belief that feeling can come back is already set. Okay, the belief that the win back will occur is now set. So now what happens is the way to get that feeling back is to continue to gamble. Interestingly, this follows the early behaviourist experiments. So Skinner box. So Skinner box, where Skinner created a box, very simple experiment, and within the box observed the behaviour of rats, and there was a lever in the box, and if the rats found the lever and pressed the lever, they received a food pellet. So what did they do? They continued to press the lever, and every time they pressed the lever, they received a food pellet. Now they know that pressing the lever gives them a food pellet. They don't need to keep pressing the lever. They can just press the lever because they know the source of food is there, and so when they're hungry, they will press a lever. So Skinner found that actually gradually the rats pressed the lever only every so often, because only when they were hungry. So then Skinner also discovered that if the lever stopped producing a food pellet, pretty quickly the rats stopped pressing the lever. Why bother? Why bother? It doesn't do anything. It's no fun anymore, and it doesn't give any kind of reward. But the most interesting thing there was that if pressing the lever sometimes, intermittently, randomly gave a food pellet, then the rats pressed the lever all the time. And, that's the same model for gambling, actually, especially if you think about fruit machines, for example. It's kind of exactly what happens. We press the lever all the time, and sometimes, randomly, we receive a reward for that. And because we receive that random reward, we keep on pressing the lever. So, the losing starts to occur. Desperation is now setting in, because now this is affecting life for many people. Okay, so, debt is starting to build up. So there can be, a lot of lies that is happening, a lot of denial, okay, and an intense feeling of stress and anxiety, but still holding on to that belief that further gambling is the solution. So kind of, a narrowing of focus here, losing that sense of, okay, well, what else can be done? And it's at this point, perhaps, that, some of the gambling charities that aren't necessarily offering counselling, but offering a lot of advice and support, can be really, really useful for somebody in this position. So they offer debt advice, support of what to do regarding issues of debt like housing, and how perhaps to minimise credit card debt building up, how to actually be blocked with some of the major gambling organisations so they won't accept further bets from you, and so on. And you can do some research in this area to find out what organisations exist in your local area if you intend to work with clients who are experiencing something like gambling issues. If this goes further from the desperation stage, then a real sense of hopelessness sets in. Extreme stressors, and this is where severe depression and possible suicide can occur as well. So people with gambling issues, there is a very high prevalence of suicide ideation, suicide attempts, and success in taking own life in some cases, sadly as well. So this is a serious issue for people that must be taken seriously, and we can understand why. Because some people from that desperation phase onwards can, find that they have gambled all of their resources. So all of their savings is gone, all of their credit cards are maxed, they are not paying their rent or their mortgage, their family is beginning to discover that the family finances have been completely depleted, relationships can break down, it can be extremely distressing and extremely difficult. So we've talked so far about people people forming addictions or dependencies, but actually one of the things perhaps that we need to look at is that this is not just a behavioural issue. So if you think back to your Year 2 studies and think back to the work that you did on self-defeating behaviours, then perhaps you can recall what's happening, what's happening for the person there, that actually very often the self-defeating behaviour is a coping strategy. It's a way of coping, it's a way of dealing with something, and often what it is trying to deal with is a whole set of uncomfortable thoughts and feelings that the person is with constantly, because it's not just environmental. It may be environmental, but people can be struggling with memories and really difficult, uncomfortable feelings related to present and past experiences. They can have a very low sense of self-worth. They could have been experiencing trauma, so abuse as a child, neglect, very difficult circumstances that not just they need to have been managing and coping with, but which leave people with a really kind of depleted sense of self. It's like feeling worthless. And that inner critic really starting to build then. The person can find that they have ingested all of those negative messages that they have received throughout life, and now there's a part of their mind that is telling themselves all these negative messages. So if we imagine for a moment that, somebody is just trying to just stop that, just stop this sort of constant flow of negative memories about self, about situations, the constant criticism of self. So sometimes people telling themselves terrible things that aren't true, but they are believing them. All those really difficult emotions, shame, guilt, hopelessness. Okay, so all of those there. It's like, well, Freud talks about ego defense mechanisms, but we can also here talk about coping strategies. Coping strategies, short-term ways to relieve something. So just going back to the gambler for a moment, it's like, okay, so just feeling very uncomfortable, hopeless, wretched, depressed, low. That, wow, I did this, and there was this sense of elation. I had this sense of confidence. I had this sense of extreme joy. I had this sense that actually at last I can do something that makes me feel amazing. So, how easy is it then to think that we've found the answer? And the answer that feels quite short-term as well. Recreational drugs, for example, tend to have an effect very quickly. People don't have to wait weeks for some kind of effect to happen. The effect happens within sometimes seconds, often minutes. Okay, so already somebody is there with that feeling. And perhaps, the feeling that somebody is trying to create is tied up with the feelings that they are trying to avoid. So, substances like alcohol losing inhibitions, feeling confident, feeling more sociable, not bound up with anxiety about what people think of us, whether people are going to judge us or not. So people drink, they don't care. It's great. Now they can enjoy themselves. Now they can relax. So substances like opiates, for example, make people feel nurtured, warm, joyful, comfortable, comforted, a feeling perhaps they've never had throughout their life or not had for a long time. So we have to understand that people aren't necessarily creating addictive behaviours for some kind of self-destructive reason, but actually often for some kind of coping reason. And then we might consider that actually the stronger the substance or the stronger the addiction or the stronger the compulsion, the more the person is trying to deal with, the more difficult, the more challenges they've had in their lives. And that's an important point to remember. So if we've had our own struggles throughout life, then, perhaps we can remind ourselves to empathise with somebody who may have had similar struggles or different struggles, maybe taken a different choice to us in how they cope with those struggles. Those struggles can be very intense for them. And it's quite common as well for people who have a dependency or a compulsion in one area to have others as well. So, very often people who drink will also take recreational drugs, will also gamble, can have eating disorders. So, it's not necessarily the case that it's just in one area. And then we might consider how people are really, really needing something to basically cope with themselves. So this here on this slide shows a possible process, not necessarily the case. So, but negative past experiences. Okay, so as we mentioned, childhood emotional abuse, attachment issues, childhood physical abuse, childhood sexual abuse. And then perhaps, that tied in with a low ability to cope, actually having poor coping strategies, having a lack of resilience, learned negative behaviours or emotional responses from others. Sometimes people who find themselves in a position of being dependent on a substance or a behaviour have in some ways learnt that, not necessarily overtly, but they can remember back in their childhood, for example, that within the family, if there was a real problem, that's when mum needed to go to bed and nobody saw her for a few days. That's when dad needed to go out and came back, having consumed a fair amount of alcohol. People learn that actually, in some cases, the way to deal with problems is not to actually try and think, okay, well, let's break this down, let's get supports, let's work out, let's put a plan in place, but let's just take the problem away as quickly as possible. Okay. So underlying emotional issues, yes, so, negative past experiences and low ability to cope, go alongside depression, anxiety, low self-esteem. So, and that function of automatic negative thoughts, negative schemas, okay, which is part of, as we know, CBT philosophy. There is a need to avoid these feelings, these memories, these images, these sensations that overcome us because of these past experiences and this low ability to cope. So feelings to avoid an irritable tension, an emptiness, a restlessness, and needing short-term respite, regardless of the consequences. So then the desired feeling, the desired experience, emotional attachment to a trance-like feeling, dissociation from negative thoughts and feelings, strong feeling of anticipation, for example, of a big win or a pleasant act, to lose oneself for as long as possible into the excitement of the game. So, as I mentioned, this doesn't occur in all cases, okay, and it would be totally wrong to make any really quick assumptions of cause and effect. We cannot We absolutely cannot think, okay, well, somebody who is, is taking recreational drugs or who is gambling a lot, we can't immediately assume that they have had a challenging and negative past. Okay, there may be a whole host of reasons. So let's now turn this around. It's like, okay, we've got a clearer understanding of how people find themselves in the position that they are in. And if we decide to work in this area, then there's a few things that are incredibly important for us to understand about ourselves. So first of all, we need a process of self-reflection. It's like, how do we feel? How do we feel about addictions, about compulsions? How do we feel about people who feel and describe that they have no control over their behaviour, that they cannot stop this, that they feel that they are addicted? Sometimes people talk in terms of having an addictive personality. I just have an addictive personality, and that feels so much like the shutter just comes down and nothing then can change. So we really have to reflect on our own feelings. So, do we feel, for example, that we put ourselves in that transactional analysis position of I'm okay, you're not okay. We're here to, we're here to fix. We're here to make something better. And we have to ask ourselves, okay, well, we have to very carefully walk alongside the client here and really be with their understanding and really be with what they know about themselves and their ability to actually change, and when and how. The person is going to be able to change this, once they are ready to do that. And that doesn't necessarily mean that's going to be straight away. And people can sometimes take a significant time to change something. And that is not necessarily always bound up with the how strong the compulsion or addiction is. So people who work in this area often use a process model such as this one here, which is Prochaska and DiClemente's cycle of change. And, this is a really good model to use. This is not a psychotherapeutic approach in the same way as the person-centered approach or the psychodynamic approach. This is a process model. This shows the process that people go through in order to change. And actually, although we're looking at this model in terms of addiction, this model can be very useful for all kinds of change. And it's particularly useful when we are working with the client as well, to understand how the client might be feeling at any particular time. So what this model says is, a starting point, we might say, for the process of change is pre-contemplation. And pre-contemplation is actually not even thinking about change. So in this process of change, it's important to recognise that many people are not wanting to change. They want things the way they are. And that's important for us to recognise in our training as therapists as well, is that you will not be able to help everybody, because not everybody will see your help as help. So it is not for you to decide that somebody needs to change something. It is for them to decide. If a client is coming to you and sitting down with you and describing their experience and describing what you are considering to be their self-defeating behaviours or their addictions, if they are saying to you, well, no, that's not the issue, I'm fine with that. That's not what I want to change. What I want to work on is this totally separate thing. Then it is not for us to judge. It may be up to us to assess whether we can actually assist, but part of whether we can assist is whether we feel personally that we can support that person in the journey that they are on. And supporting that person is not allowing ourselves to make judgments about what they should be doing and what they shouldn't be doing. So that's important to remember, that actually many people who have addictions or have self-defeating behaviours are in pre-contemplation. They found a solution, or they're happy with it, or they're not too bothered about it. Okay, or occasionally they just think, oh yeah, I should do something about that. And You might find actually in your discussions when people ask you what you're doing at the moment and you tell them you're training in counselling, very often people can talk to you about what's going on in their lives, but actually they are talking to you not as a client, they're talking to you very often from a stage of pre-contemplation. Oh yeah, I guess I should do something about that sometime, but hey, it's okay, I quite like it. So it's unlikely that a client is going to arrive in your therapy room for any kind of support in a pre-contemplation stage because they are not contemplating support at this moment. If they are in contemplation stage, then they are actually perhaps considering it more strongly. They are thinking that sometimes this is an issue. They are thinking that actually they do need to do something about it. They're not doing anything about it, but they are contemplating it. They are becoming more aware of, perhaps statistics and reports about, what it is that they're doing. They're becoming more aware, perhaps, of the negative side, the dangers of what it is they're doing. They're becoming more aware of where it might lead. They're perhaps talking to people about it a little bit, but they're not actually doing anything about it yet. It's also a stage where people may not yet come to therapy. They may not yet be ready for support. More likely is that they come to therapy perhaps in preparation stage. It's like, okay, now they're actually thinking about the change. Now they're actually talking about the change. Now they're actually beginning to, in therapy perhaps, want to set goals about this. Actually want to think, well, how could this work? What could I do? And then, your skills as a therapist is helping the client to find those ideas and those insights and those resources that they have that will work for them. Not your ideas, not what's worked for you, not giving advice, not trying to lead the client too quickly, giving them space, giving themselves time. Perhaps like the other parts that we've just looked at, people can stay in preparation stage for quite some time. And that's okay. That's okay because, the whole idea of this process model is to recognize that actually, people are in different stages of this process. Preparation can then move forward to action, the action stage. Okay, now I am doing it. Whatever it is, I've made the plan, I've prepared, now I'm doing it. So now I have the support that I need. Now I have the appointment with the GP. Now I am in the process of withdrawal. Now I am withdrawing. Now I have got help from where I need help to stop the gambling, and now I have stopped. The person has taken action. Okay. So again, support in therapy can be really, really helpful at this stage, but again, it has to be support working alongside the client, not trying to push them forward or pull them forward to where they're not yet prepared to be. Action stage, a fair few people say that actually, stopping their behaviour, stopping their addiction, is easier than actually maintaining that change. It's the maintenance part that is the problem. That's the difficult part. Because, of course, having taken the action, what the person has actually done is taken away those coping strategies. Now, the real work, perhaps, of therapy comes in where now the person needs to be supported to begin to understand and gain insight of all of those things that are now in their awareness. So people find, for example, that their sleep pattern can change. They can have very uncomfortable dreams. They have flashbacks of memories of uncomfortable things. They can find themselves feeling very depressed. They can find themselves with a high level of anxiety. Okay, and they can find themselves with those uncomfortable realizations and memories of how their past has been, or how they don't feel capable of actually doing many of the things that they need to be doing now to just keep things moving on an even keel. So the maintenance can certainly be tricky. Now, it's not necessarily that maintenance leads to relapse. Actually, relapse in this cycle can occur at any stage. Okay, relapse is like, all right, well, either I stay here I stay clean, I stay dry, whatever, okay, or I relapse. I find myself using the substance or doing the gambling or whatever once again. Relapse is considered to be a really important part of this cycle. It's a really important part because it's the opportunity for the client to understand what happened there, what were the triggers to this, what led to this, what did you do and what happened next. And all of this can be a great learning opportunity for the client. So a great learning opportunity to actually learn from, actually to, in some cases, need to go through the process of relapse in order to learn from it, because it's a recognition that life going forward is not going to be perfect. It's not perfect for anybody. And therefore there will be these triggers. There will be these occasions where temptation is there. And actually, it's learning from it. It's like, right, what happened? What can we do about that? What do we need to talk through? What support do you need there? And importantly, what did you do afterwards? So very often people can get into this vicious cycle with themselves. It's like, I felt terrible about myself. I took the substance. Then I really beat myself up because I was doing so well. And then I took the substance again because I'd really beaten myself up because I shouldn't have done that. And the cycle goes around and around. It's like, it sounds counterproductive perhaps to support yourself and say, okay, that was all right. I'm learning from this. I don't need to keep doing this. I can stop this now if I wish to, or I will get back into this cycle when I'm ready to, but I'm learning from this. So relapse is a very important part of the cycle. And actually what Prochaska and Di Clemente have found in relation to this cycle of change is that very often people go around this cycle several times. So they relapse and then they come back into the cycle. Not necessarily at pre-contemplation, but sometimes they do. They might come back in at preparation, or they might come back in at action. It's like, okay, I'm trying again. Okay. And the more times people are willing to just go around the cycle, the more chance they have of complete success. Okay. So an important model that you can certainly use. So we've spoken about you being able to support the client at various stages in that cycle. And how do we do that? Well, we use our core conditions, we use our empathy, we use our support that we know how to provide. We can also use a style of therapy called motivational interviewing, and this is used in addiction work a fair bit. And it is something that is person-centered, so it uses everything that we already know about person-centered. It uses the core conditions, but it also works to add something there. It works to add something, okay? So motivational interviewing has these important aspects to it. So expressing empathy. We know what empathy is. We know about using reflective listening. We know that we are aiming to understand the person and to understand their perception of what's happening and their underlying motivations. We're working to understand, okay? And we are using all of those attending and listening skills that we know how to use, reflecting, paraphrasing, summarizing, okay? But we are also developing discrepancy. So developing discrepancy is like, it's like opening up ideas for the client, okay? So discrepancy between the client's deeply held values and their current behavior. Now this relates to something that we call cognitive dissonance, where we feel that there is a conflict within ourselves. So again, similar to the person-centered approach of that conflict between who we feel we truly are and who we feel we have to be, and trying to fit ourselves into that box that doesn't fit. Okay, who we feel we truly are is bound up with our values. So discussion with the client around what's truly important for them. What's truly the life that they want to lead? How do they want to be supporting, for example, their family, their children? What are their ambitions? What do they feel is important in their life? And then how do they feel they're doing with that? Do they feel that they are living their values? And values can be so powerful, they are a driving force for us. And so developing this discrepancy between the client's deeply held values and what they find themselves doing. It's like, well, I want to build a good life for myself. I want to raise a family. I want to just succeed. It doesn't have to be enormous. I just want to be happy. I just want a nice roof over my head. I want to feel secure. I want to love somebody and be loved by them. It's like, okay, how's that doing? Are you on that pathway? It's like, no, because I've just spent my last £5 and I don't get any more money now for the next week. And no, I'm not on that pathway. And obviously this needs to be supported and, and carefully brought about. Supporting self-efficacy, so building clients' confidence that change is possible. Supporting those moments when they're telling you how hard they've been working this week and how it's gone, and and then playing down perhaps for them their natural tendency to focus on the negative. I was doing so well until Friday and then it all just completely went downhill. It's like, okay, let's come back to before Friday, shall we? Let's remind ourselves how it was before Friday. So you said you were doing really well. What happened? Tell me about it. So yes, actually focusing, helping the client to adjust for them that tendency to think critically and think negatively, and to also focus on their resources and what went well. Sidestep resistance, okay, or sometimes called roll with resistance. So we respond with empathy and understanding rather than confrontation. It's very important that we as clients remember, we as therapists remember that we are here working on behalf of the client. The client's goal is their goal, it's not our goal. And if the client starts to withdraw in what we're talking about, starts to cancel appointments, starts to ask for appointments further apart, then we have to consider that is therapy trying to move them too fast? And they can't do that. And sometimes it's not as obvious as that. It's a moment where the client just seems to glaze over, just dissociate from us, just stop being connected to the session, and we realise then that that they don't feel that we're with them. So we have to be very aware of that. We're supporting the client here, not trying to push or pull them. So employing a pluralistic approach, motivational interviewing fits within this, okay? So pluralistic approach, remember, is collaborative, it's individualised, it responds with client agency and client resources. So process models such as the cycle of change that we've just looked at, and indeed have some similarities with the stages of change model of Rogers, can very easily be integrated into the pluralistic approach. Therapeutic relationship is incredibly important. So we can use person-centered approaches and bring in motivational interviewing, which you will hopefully have the opportunity to understand more about in class and to practice. We can use structured and goal-focused approaches such as CBT, and we can promote other areas such as self-help and work that clients can do for themselves alongside our help. Okay, so, and bring in other sources of help as well that we can work alongside. So medical help, charities, legal, financial, practical help. Another important aspect of this work is going to be the importance of supervision, because understanding our own responses, understanding what's happening, and finding that sometimes, this work can be very triggering for us as well. It's interesting that a fair few addiction counsellors have been through their own issues with addictions and are considered that actually this work is well suited for them because they have an instinctive understanding of what the clients they're working with are going through, and the clients feel in many ways that actually, yes, you understand me more, I can work with you, I know you're not going to judge me. So, self-reflection and understanding here is important, and we know that one of the main ways self-reflection is through supervision, and having good supervision in place is really, really important for this work. So there are various supervision models. We've looked at a process model for change today, but there's also a process model for supervision. In fact, there are several. One of the main ones that we like a great deal is the seven-eyed supervisor model, which is demonstrated here on this slide. And the reason why this model is popular and so well respected is that it looks at possibly every aspect of the therapeutic process. And that is not just what is happening for the client. So it's not just what we take to supervision, we just talk about what's happening for the client and how they present it, but it also explores much more than that as well. So it will explore, for example, our choices based on the assessment of the strategies and interventions that we think are going to be most helpful for the client. It explores the relationship between the client and the therapist. So what was happening in that relationship? What dynamics were occurring at different stages within that relationship? It explores the feelings of the therapist themselves. So, did we feel triggered in the session at all? What were the feelings that we were with? What were the feelings we were with before the session, and indeed after the session? What are our feelings now? And it focuses on the supervisory relationship. That's the relationship between the therapist and the supervisor as we're talking about this. So what's happening in that relationship? Is there any parallel process at play? The supervisor can also focus on their own process, self-reflection on what is occurring and whether there is any transference or projection or interjections happening there. And then focusing on the wider context in which work is happening. So ethical issues, safeguarding, referral, but also the policies of the agency or organisation within which you're working. So it is a holistic model, very useful, and it doesn't mean that every session there would be focus on all of these different aspects. In fact, there might be several sessions that are focusing on one aspect, but it does mean that this supervision model recognises that supervision focuses in many different ways. Okay, so we've had quite a brief overview of an important subject here today, addictions and dependencies. Thank you for listening, and hope to see you again soon.